share them if you like.
Okay.
It might be easier.
I'll let you share. All right, we'll go ahead and get started. Good afternoon, everyone. My name is Melinda Southard. I serve as a Deputy Director here at the Nevada Health Authority for Community Engagement and Workforce Development. Really appreciate you all making the time today to join the listening session about the Rural Health Transformation Program, specifically the initiative for Rural Health Information Technology. This listening session is meant to gather public input and feedback on, what's working, what's not working in terms of health information technology in our state, and will really help to inform a really great request for proposal that we're going to be issuing here coming up in a few months. So looking forward to some engaging discussion today. Appreciate you all, just participating in today's listening session during those appropriate times. And with that, I'm going to turn it over to the HMA team. So Lee, if you want to go ahead and share your slides, and I'll hand it off to you guys.
Excellent. I'm going to put on some glasses so I can read our slides. Always a key part of it. So here you go. I think they're shared. And with that, I'll let Arun kick off the discussion.
Thank you so much. Hi, friends. My name is Arun Natarajan. Grateful to be here, and I'm joined here by my colleague today, Lee. Incredibly grateful to the entire Nevada Health Authority state team, and Melinda, thank you so much. So we're working with the Nevada Health Authority to support the design of the Rural Health Information Technology Procurement. Our role here is to help the Nevada Health Authority translate the goals of the Nevada Rural Health Transformation Program into a procurement and funding approach that is practical, provider-led, and grounded in real-world experience, real-world rural experiences. That includes thinking through things like project scope, eligibility, sustainability, expectations, and how to structure the support so that it's usable for rural, frontier, and tribal providers. Importantly, we're not here today to evaluate proposals or make funding decisions. Today is about listening. Your feedback directly informs how the RHIT is going to be designed, what's realistic, what barriers need to be addressed, and what kinds of health IT investments would actually make difference on the ground. Next slide, please. Also, while we're just a few housekeeping rules, there's going to be plenty of time for everyone to share their comments. At this point, we've got a couple slides that we're trying to get through. And if you want to use the chat at any time, please feel free to use the chat. It would be helpful also if you're using the chat or you're raising your hand to share, identify what kind of provider you are. I'll say this a couple different times, but just identify what kind of provider you are and who's the population that you're serving. And where in the state. That would be helpful. Not necessary, but it'd be definitely helpful to hear before you offer your comments. Okay, so now the RHIT listening session agenda. Let's get to the agenda for today really quickly. We're going to start with a brief welcome, look over our session goals, then a high-level overview of what RHIT is, and then some examples of potential projects. We'll spend the majority of time in open discussion and then close with next steps. Just to underscore what's on this slide, this is a listening session. No preparation is required, and we're not expecting anyone to come with polished ideas today. So let's start with what we're trying to accomplish. Next slide. So today's goals. Our goals today are fivefold. The first, we want to share context for what RHIT is and isn't. We want to hear directly from rural, frontier, and tribal providers about your real-world experiences with health IT. And we want to understand what's working, what isn't, and what barriers make adoption or sustainment difficult. Finally, or fourth, we want to use your input to inform the procurement design, including scope, priorities, and what kind of supports and support approaches could be most helpful. We're not looking for proposals today. We're looking for honest input about what's realistic in rural settings, what's working and what's not working. So with that, let's do a quick review of RHIT, and I'm going to kick this back over to Lee.
Thank you. And you'll notice as I say rural more and more, my pronunciation of it will decline. I apologize in advance. A difficult word. What RHIT is. RHIT is a provider-led grant program under Nevada's Rural Health Transformation Project. At its core, it's designed to support practical, real-world health IT investments. This program is about progress, not perfection, and it doesn't have to be about overly complex solutions. A key point here is the state's role. Nevada serves as the steward and funder, not the owner or operator of any IT systems. That means that providers remain in the driver's seat when it comes to what gets implemented, how it's used, and how it's sustained over time. What RHIT funds? RHIT funds projects across 3 tracks. Track 1 focuses on the fundamentals, things like EHR or electronic health record access, interoperability, cybersecurity, and data exchange. Track 2 supports provider-facing tools that directly enable care delivery, including telehealth, remote monitoring, and hybrid care models. Track 3 is more limited in scope. It includes consumer-facing digital tools, but only, and this is important, when they reinforce provider-based care rather than replace it. We're going to talk a little bit more about the tracks in a moment. How RHIT is structured. Projects can be any size and should be appropriate to your organization's current capacity. Some projects may span tracks, and this is acceptable as long as the scope is clear, feasible, and easy to understand. Across all tracks, RHIT emphasizes a few consistent principles: rural benefit, real-world feasibility, shared or scaled solutions where possible, and sustainability beyond the grant period. Here we provide a few examples, not a required list, of projects this funding may support. For track 1, think core infrastructure, EHR access, cybersecurity projects, and data exchange capabilities. For track 2, think provider-facing tools that enable care delivery transformation, such as telehealth, remote monitoring, and virtual hybrid care. Finally, there is track 3, consumer-facing AI and digital tools. Again, you'll notice track 3 is intentionally limited both in funding and in scope. That's a deliberate design choice, and we want to briefly explain why. First, RHIT is fundamentally provider-led and provider-anchored. Track 3 is limited to ensure that any consumer-facing tools directly reinforce provider-based care, rather than operate independently of clinical workflows. Second, standalone consumer and AI tools carry higher clinical, privacy, and cybersecurity risks, particularly if they are not tightly governed or integrated into care delivery. And finally, there are sustainability considerations. Consumer tools often require ongoing licensing, updates, and support that can be difficult for rural providers to sustain once grant funding ends. As a result, RHIT prioritizes limited funds towards foundational needs, such as core health IT, interoperability, and care delivery enablement, where rural gaps remain most significant. Track 3 is therefore limited to non-clinical, appropriately scoped tools that extend care between visits, not tools that diagnose, treat, or replace clinicians. Arun is now going to talk a little bit about project requirements.
Thank you
Arun?
so much, Lee. Sorry about that. Just had to get off mute. Project requirements. So these are the major requirements that we're going to be considering. The goal is to set clear guardrails while keeping projects realistic. So the first is the project must be provider or tribal led. The state is not the end user. These projects must demonstrate rural benefit, access, workforce, care delivery, or operations. Next, solutions need to be vendor neutral and standards based and support interoperability and alignment with the CMS technology ecosystem. Projects should also address cybersecurity and lifecycle management, privacy, security, maintenance, and upgrade plans that fit scope and capacity as relevant. These projects should also be scalable and transferable. Even if it's on one site, it needs relevance beyond one's organization. And it'd be great if we could think about replicability. What lessons learned can this project have for the overall ecosystem? Finally, there should also be a sustainability plan. How are you covering operating, licensing, staffing costs after RHIT funds end? Projects have to also meet all federal requirements, including quarterly annual reporting requirements. Next slide. So now we're going to break straight into our open discussion. Again, please use the chat. We've got by my count, we've got about 112 discrete logins here. That's a lot of people, which is super exciting. We're going to go first through the first 4 questions. What's working well with Health IT today? What are your successes? What are you experiencing in terms of your biggest challenges or gaps? What barriers make it hard to adopt or sustain Health IT? And finally, what kinds of support would make the biggest difference? After we have a little bit of discussion around those 4 points as we're listening, we'll then move to the final 2. What kinds of projects would you be interested in pursuing with rural Health IT funding? Would you consider partnering with other community organizations, vendors, counties, providers for a project? We'd love to hear from you. We'd love to hear what you're thinking about in each of these 6 areas. Let's try focusing on the first 4 questions now. Raise your hand. This is a listening session. We're going to try keeping comments to 3 minutes if you can, 3 to 5 minutes max. Please identify yourself, what kind of provider you are, and where you're providing services. That would be super helpful. And then let us know which prompt you're trying to think about. So this is your time. Would love to hear from you. Okay, Dr. Bryant, thank you for raising your hand. Can you unmute yourself?
Yeah. Hello, my name is Dr. Bryant. I am a general dentist and I run a nonprofit, the only dentist-led nonprofit in the state. I go to 8 counties and provide school-based dental care. We currently use a portable clinic, so I bring it in and I bring it out. We have enormous IT issues that are as minimal as sometimes the schools won't give us their Wi-Fi password, to as major as there are new EHR requirements that we have to have a patient facing portal that has to be approved. And currently in the dental sphere, there's only 2 programs that meet that minimum requirement, and their subscriptions are $1,600 a month for these approved IT programs. Again, we have a staff of 4, and we treat a few thousand kids a year, but that is just a little bit much for us. And the program that's approved is Dentrix. It's a very robust system that has too many bells and whistles. We wouldn't even be able to maximize all the other features. So I think that those are just some of the things that make it difficult to adopt and sustain Health IT, are that the compliant programs are not affordable for small nonprofits.
Thank you very much, Dr. Bryant. Very much appreciate that. What experience do you have with personal health records? Is that something that's not being leveraged, or, I mean, what is your experience with parents if you're dealing with children on the PHR side?
We do everything in paper. We do everything in paper.
Thank you.
Also, school districts, since we're at the school, we provide the school with a paper copy. And it's also difficult because our IT doesn't always play well with schools' IT and schools' requirements. So I would absolutely be willing to work with any and all counties in the state to figure out something that can help meet the needs of our students and our parents. I think it'd be great for health and med. A lot of our schools use our information to help in other cases like, CPS cases and other child behavioral cases, IEPs. Knowing the status of dental care is important for a lot of things.
Thank you so much, Dr. Bryan, and thanks for kicking us off here. Again, would love to hear from everyone. What's working well with Health IT? What are you experiencing biggest challenges or gaps? What barriers and what kinds of support would make the biggest difference? Diana McGinnis, over to you. You can unmute yourself.
Hi there, I'm Diane McGinnis. I'm a nurse practitioner and I have a rural practice in Beatty. And I did previously work there with Nevada Health Centers, so I have quite a bit of experience in that corner of the state. And the IT, as far as we are able now to get broadband in Beatty, but it is running about $100 a month, which isn't too bad considering. But when I have to go out to some of the outlying places and do a house call, I often don't have service there, or I use cell phone modem. So just strengthening the cell phone modem across the state would be more important to me than just plain broadband. Also, Healthy Nevada, being able to access charts of patients that have been seen in hospitals and other clinics in Southern Nevada, as many rural patients often just decide to go to the doctors while they're going grocery shopping and things like that. So that's helpful. The Healthy Nevada is also a fee, and getting some sort of assistance with that would be helpful as well. As far as a regular Health IT and patient access portal, I'm on the healthcare side, not the dental side, and so I am able to do that with my product that I have. And I'm open to any questions as well.
Thank you so much. I'm curious, what's working well with Health IT? Are there successes that you can point to?
I just have a normal electronic health record, and the same one that I could use in the Las Vegas metro area, I can use because I have the broadband access. And I can also, like I said, access it via cell phone modem if need be, using a laptop. But the hardest part is when the distance or the dead zones.
I hear you. Thank you very much, Diane. I appreciate your comments. Super helpful. Okay, team. We've got 116 people. I'd love to hear your perspectives.
Yeah, we have a shy crowd here today.
JC Flowers, you can unmute yourself.
Hey, good afternoon. Thank you for the opportunity today. I'm Jesse Flowers with Nevada Health Centers. We operate FQHC clinics in Pahrump, Amargosa, Elko, Carlin, Wendover, Austin, and a few other locations. So I think one of the things that we'd like to get clarity on is when these are coming out, and a lot of that's around RPMs, remote patient monitoring, what's that's going to look like, and the sustainability of that beyond year 2, year 1, year 5, and because those will have to be overturned, as they live out their shelf life. But really kind of when you put out the proposals, kind of talk about what aspects of RPM that you really want to see. I think that, is it just the equipment? Is it the equipment and the fees? Is it what are you all looking at from a state perspective, and then how is it going to be encouraged to be used by the practitioners so that it can be documented in the EHR? So a lot of times when we talk RPMs, I think things that are left out are like the interfaces that have to happen between RPMs and the electronic health record, medical record. So really would like to make sure that when we see them come out, kind of having some clarity around what all you want to put in, what you can put in, and things like that. Because I think that's important for us to understand if there's guardrails on the side of that. What do we need to? We may get funds for this piece, but we'll have to allocate funds for another adjacent piece or something to that. So that would be just kind of questions for the state and for you all as you're putting it together to help us guide us in a direction in which it's going to accomplish your goals. What are you looking at to do with that? And I think that's been said several times. I mean, we could get an HIE, and I don't know how you do that because it's not going to be one of us putting that in our bid, but maybe the state allocates funds for rural hospitals and rural providers to be interconnected, at least in the rural areas, because obviously it's a rural transformation grant, but at least to get that connectivity existing. But I don't think that's going to be any one of us doing that. That's going to have to be a collaborative. So keeping that in perspective as well. Thank you.
JC, thank you so much. Do you mind if I ask a few follow-up questions?
No, please do.
So just going through the prompts, is there anything that you, question 1 or prompt 1, that you would identify as a success around health IT, something that you think might be a replicable practice or a promising practice that others could learn from?
Well, I think there's a couple, and Bill, if Bill is on, Bill Cohen, if he's on the call, I know he was going to join. He's
Yep,
our IT.
Bill is here. Bill, do you want to
So
unmute?
I'll start and then
I just
I'll turn it
joined,
over to
yep.
Bill. I think that we have some radiology connectivity that's worked. And you know, I'll let him answer the rest because he's the IT guy.
Well, thanks for putting me on the spot, JC. Glad to help out. No, seriously, you know, the telehealth portion has been wonderful for us. As broadband access has increased in some of the rural areas, we've been able to upgrade our circuits and better provide services to our patients in the rural areas. And you know, 18 months ago or so, we switched EHRs and we're now on Epic, and we're seeing a much better coordinated care through that EHR system for our patients. I think those are a couple of highlights.
That's great. Thank you. Were there specific challenges that prompted the switch to Epic, may I ask?
Yeah, I mean, I can answer that. Well, Bill, go
Go
ahead.
for it. No, go ahead, JC.
Well, I know you're traveling, so that's why I was, you know, I think the interconnectivity that Epic provides with, you know, other hospitals and other folks with Epic, I think the MyChart aspect where communication with the patients can be improved. There were a lot of reasons to move to, you know, it's a Cadillac. It's expensive. It's really expensive for those that haven't ventured. But so I think cost sustaining with that to continue to expand the case management and the other coordinates of that, which are essential in the rural areas. Obviously, you're going to use an urban, but some of those case management models, some of those TCMs that you can do virtually, I think that the ability for Epic to kind of see healthcare as it is today, you know, I think that's really it's a benefit to us and to our patients because it really connects them a little better. It's not a standalone storage facility, you know, of an EMR. It's interconnected. I don't know, Bill, if you want to add to that.
Yeah, and I'll add that our previous system was problematic. Every version upgrade brought a new set of problems that we had to deal with. The company had been purchased out by a publicly traded investment firm. So for us, you know, kind of the writing was on the wall to look for an alternative. And as JC said, going to Epic, the Cadillac of systems, was what would be best for our providers and for our patients.
Thank you so much. That was very helpful.
You know, one of the things that you said on your prompts here, some of the barriers for IT health is we're also in some of the schools with our telecarts and things like that. It's you know the authorizations from parents and others when patients do need to be seen, children need to be seen. So there are challenges that are just inherent in healthcare. But so some real-time solutions to that may be effective. I don't know. There's a few out there where, you know, you can get virtual signatures and things like that. It would be really important when you're dealing with the schools and getting that stuff done. But I think that again, some of these projects are going to be community based. So as the bids come out and as providers, we try to coordinate with other community organizations and other solutions, but it's going to be really hard for us to say, okay, we can be the sponsor of this, but we can't do it alone. So how are the proposals going to be taken to say, okay, well, this healthcare center can take care of this component of it, but the other part has to be awarded to this other individual entity that can do this part of it. So I don't know how that's going to happen, but I think it's going to be extremely important and necessary. So some thought into that from the state level on how do we do that? Is there a way, say, okay, part A gets awarded, part B has to be awarded? I mean, I don't want to make demands like that, but there's going to be hand in hand with our community partners so that we're not all trying to do the same thing, but we're all benefiting from a more global participation and funding, I guess is the best way I can say it.
And that's well spoken. Thank you.
So again, we've got about 115 people. I'd love to hear more perspectives on what's working well with Health IT and what are some of the biggest challenges or gaps. We've heard challenges around funding, broadband access, connectivity. What kind of supports would make the biggest difference? Be great to hear some perspectives from people on that. Sure, let's go with Jerry, and then after Jerry, Shannon.
Jerry Reeves, I'm a medical director with Comagine Health that operates in multiple states. And some states where we operate, there are health data utilities that are much like, you know, electric grids or water governance that is a public-private partnership, such that some of the things that JC was describing with the challenges of silos in each community having no coordination with the other communities, when rural Nevada is really one big community. We need to have better interfaces and public health partnership governance of interoperability and collaboration, both case management, care management collaborations, and resource collaborations to optimize efficiency and sustainability, to deploy the health information and data utility resources as efficiently and effectively as possible.
Thank you very much.
Thank you, Jerry.
Shannon, would you like to unmute yourself?
Sure. Good afternoon. I'm Shannon Ernst. I'm the administrator for Central Nevada Health District, which we serve Churchill, the city of Fallon, Eureka, Mineral, and Persia counties. I think our data challenges have really come up with, we try to build dashboards so that we can engage our communities and know what certain diseases, outbreaks are taking place. But the challenge is getting the data from the state side. And I would love to see a project where we can build these bridges so that we have dashboards for all of our communities. We're currently going through a project, paid some funding to develop our dashboards, but now it's a manual process. And so when I look at that for our transparency for all the communities, I think it would behoove us to look at how we can increase it from the state to our other jurisdictions so that we don't go through this manual process.
Super helpful, Shannon. Is there anything else you could sort of share? Could you kind of tease that out a little more?
Sure. You know, when you look at most go through the EMR systems and it's going in from our healthcare providers across all the rural areas up to DPBH. And so that's where it's housed and in their data systems. We really want to get to data that really is communities we're serving. That's what they're asking for. They want to see what our hospitalization rates are, those things of sort. And currently, as we build out, we are learning those challenges. We have to contact and obtain the data and then manually put that in. There's no bridge where we can build between the two systems to do that automatic data, if that makes sense. And I think this is something we've pondered. Now, I think I've been working in this realm for about 17 years, and we continually have that. And I'd love to see how we can build across the rural areas to have that work at the state level down to our community levels. And I think
Thank you.
Melinda knows exactly what I'm talking about. I think we've all screamed about this for years. But we're really hitting it ahead now, and it costs a lot. And so for this project to be sustainable for us and building our database, we really need to find where we can build those bridges so it's not cost restrictive for us to maintain them and make sure the data is accurate.
Thank you. Really
Thank you,
appreciate that.
Shannon.
Again, would love to hear from everyone. We've got a lot of people on this call. What's working well with Health IT? What are your biggest challenges or gaps? If you've already heard someone share one of the challenges that you're facing, it would be helpful for you to re-echo that. Say, yes, I agree. That is a huge pain point. We've also heard, I think, sort of some projects that would be interested, that there seems to be some interest around pursuing. Are there any other projects that anyone here would be interested in pursuing with RHIT funding? And what are the challenges with partnering with other community organizations? Is it just a logistical issue? Would love to hear from you.
And we see the comment that silos are an issue. Keep in mind, the whole state of Massachusetts fits inside NYE County. We have other counties with the same issue. Population based in only one corner of a county does not make the whole county accessible. We hear you. I'm going to record that comment and thank you. DF. Diane.
Again, please use the chat as well. If you'd rather put your comments in the chat, we'd love to either take it in the chat or you could raise your hand.
I'm seeing a comment from, put the glasses back on, Michael Gagnon. Health HIE Nevada is ready and willing to be the health data utility for all Nevada. So that's an advertisement for Health HIE Nevada. So are there opportunities to partner with other groups too? That just brings to mind partnerships that you would find ideal kind of alluded to a few of them in the comments you've had so far. Pointed out that there's a lot of silos across the state, as there are in most states. So if if you have any ideas of partnerships that would make sense, we'd like to hear about that too. Ways to break down these silos. Any collaborations between medical and dental would be so helpful. We see students all the time that need medical referrals. Do we want to talk about that a little bit more? That's a really great comment, Dr. Bryan.
And folks, remember too that, your comments today and, suggestions are really helping to shape how we formulate the request for proposals that will come out through state purchasing. So the more participation and information that we can glean from you all smart folks would be highly appreciated. Thank you.
Yeah, as a dental provider, we operate on an island, but as healthcare providers realize that it's a whole human, not just a mouth or the rest of the body, it is very difficult to treat students and see behavioral, oral health. We've got vision, hearing. There are just many concerns when you're seeing these students in a screening situation that come to light through their oral cavity. I mean, diabetes has an inflammation component. We've got so many swollen tonsils that nearly touch. Airway is a huge component. Being able to sleep, chronic headaches and pain, infection, all of the above. I think behavioral health, we deal a lot with students who might have strange home lives or they reveal things to us. It's just very hard because we get a student with one encounter with one sheet and we get no insight into their medical background, and we have no way to forward our medical concerns aside from a form that just says CENT or recommend, I don't know, allergy. We get a lot of, facial sores or, a bunch of things that are outside the scope of a general school nurse, but we're the only provider that they see in that setting. So unless their parents are actively taking them to get care, which is difficult, Pershing County doesn't even have a dentist. I'm not sure what their access is to medical care there, but I can't imagine it's much better. So transportation in a lot of these counties is a huge issue. And so I can't imagine they're getting specialty care. I think that if we could use IT to at least put in referrals to the medical colleagues, that alone would be huge. Because right now I have to refer them back to their primary care that they may or may not even have. And there's no documentation aside from in their school file and what I hold.
These are great insights. Thank you.
Is there any successes that anybody on this call has had with closed loop referrals, with electronic referrals, where there's someone you can send it to and a receiving party to catch the referral?
This is Jerry Reeves in Las Vegas. We have a community health worker project that's Pathways Community Hub, where the social determinants of health information that they gather when they are visiting high needs patients in isolated settings who live in disparities neighborhoods, communicate their social needs, unmet needs with the clinicians, with the clinical information and services, so that you're integrating both the poverty and the education and the transportation challenges to those with clinical expertise to address those needs, and telehealth deployment for seniors and for isolated adults in rural communities has really been a dramatic godsend to help communicate between urban centers that have expertise that are isolated from rural settings, but these people have real needs in these rural settings that can be met with connectivity, whether that's clinical information connectivity or social determinants needs connectivity. So it can be done, and it doesn't take a really expensive set of connectivity tools. There are tools that really work at interoperability between not just clinical providers, but also clinical and health services, health needs, social needs providers.
Excellent. Thank
you
you.
very
That's very
much.
helpful. I also see in the chat, I would like to see some sort of OB-GYN health IT where my pregnant ladies could get better care. Also, maybe like Alaska, some sort of funding for our ladies to wait before they deliver near a hospital. So funding to wait, housing support, I think you're saying, near a hospital instead of coming in for the elective C-sections for safety because they can't afford to wait in a hotel.
Yes.
Thank you very much for that comment. Robin, asking you to unmute.
All right. Well, I figured I'd boldly step up to the plate because I agree, we can't have this big opportunity and nobody really speak up with what opportunities are needed. I apologize, I was a little late to start, so if I'm repeating a couple of things or maybe missed the context of it, I apologize. But a couple of ideas. By the way, I'm Humboldt General Hospital CEO in Winnemucca. A couple of spaces that I think are really important when we're looking at health IT for our organization as well as rural communities is, the AI components that are coming out in our EHR softwares. I think that potentially was already hit already, but, ambient listening, AI tools to help reduce administrative burden so our providers can actually spend more face time and see adequate and supported amount of patients versus the administrative burden of it all. I really love some of the EHR platforms. Now I know everybody doesn't have as advanced EHR platforms, so that's varying, but the work coming on the revenue cycle side of AI to help support that. We currently don't have any of those AIs built in, and so we would of course look to be doing some of that. One thing I think is really important in context of our current situation with cyber risk is, we spend $750,000 a year as a small organization for our external cyber support from an external company, and we're blessed enough to be able to have the ability to have that. I think there's very large concerns in healthcare IT space for the safety of our networks. And our ability as small organizations, including all the small FQHCs and RHCs around with, okay, we get all these technologies, how are we keeping them safe? It would be incredible to have some kind of opportunity to be able to have some large company help us with that space, with PII and training and educating our staff to properly use and making sure nothing's coming into our system. I'm going to echo telehealth. Winnemucca is a larger rural community, and our hospital is larger than most of the critical access hospitals, and our telehealth support is next to nothing. Expanded subspecialists, rheumatoid, neurology, endocrine, GI, cardiology, even expanded telehealth support would be incredible because it would really eliminate our community from having to travel. I heard transportation was a big hit. I mean, this isn't the transportation discussion, but I mean, why not have self-driving cars in rural Nevada? We've got them in large or spaces. Why not? Why not at the 5-year mark finally install something that would get our rural communities to get to tertiary support, if needed. So those are kind of some of my thoughts. I don't know if
Thank
that's
you,
what you were
Jen.
looking for, but I
Yeah.
wanted to at least help.
No, Robin, I appreciate that. One of the challenges that we're trying to address on the cybersecurity and the risk side is ensuring that RHIT funds under Track 1 can definitely be used for that continuum of assessment, certification, and implementation, ensuring that there are robust cybersecurity measures in place to
I think the
support.
challenge is the sustainability of that, right? I mean, we have to prove sustainability. Well, those companies are very expensive,
Mhm.
like you can get the first year ramp up, but how do you sustain it on, when this piece isn't necessarily bringing in a revenue stream that'll help support it? It's tough.
It is tough. So, Robin, what do you suggest in terms of thinking through the sustainability piece? What do you suggest in terms of not providing extensive burden on the part of the provider, but also ensuring that the state is able to demonstrate its due diligence with CMS? What do you think would be a happy medium there?
Yeah, I mean, I think, if there is an opportunity to partner with a large firm that does this for many, and can get us significantly reduced pricing so that it is sustainable. I mean, obviously, access to healthcare is slammed down to nothing when we have a cyber attack and have to go to downtime procedures. So, I mean, I think that getting as reduced to pricing is going to be key to this. And the only way to get reduced pricing is to have bulk contracts, in my opinion, anyway.
So I've got a question following up on that, which is how do you think whether it's the state or an organization here could support in bringing multiple smaller organizations together? Like what would that look like? What could the state do to support? Or I mean, it's open, right? That's the point. It's open to this idea.
Yeah,
So now how do we think through that?
yeah. Well, I think it's, like a potentially year 3 or 4 after some silo breaking down and collaborative
Mhm.
models developed for shared. I agree. Somebody said that we're very siloed. I agree with that. I think one of the most special things about rural locations is that we love to fend for ourselves. That's one of our one of our best characteristics. In this situation, probably one of our worst, because we don't collaborate super well together because we like to stay independent. That's why we live rurally. So I mean, I think that the challenge is getting everybody collaboratively working on a solution. Somebody's got to make a proposal that a vendor that everybody really trusts, and like, and propose the risks that are out there sitting at our facilities. Just because you haven't had it doesn't mean it's not if, it's when it's going to happen to your organization. We had a major cyber attack and it cost us millions of dollars and months to recover. Hence why we have that huge external contract covering us
Yeah.
now. Yeah.
Yeah, I mean, we've all seen stories of hospital systems that are dealing with some sort of ransomware and have had to now go to 100% paper charting for the next 2 to 3 months until they could
Yeah.
address the issue.
Well, and I think, our IT departments I can only imagine dental offices and FQHCs and our organization, I can say as a whole, this is a space that you really struggle to be able to stay proficient in and top notch with the skill set that you have in your communities. So is there an opportunity to even develop, the IT knowledge base of rural communities. I don't know. They're just outreaching ideas, but it's a challenge.
No, thank you very much. We've also, Lee, we've got a couple comments in the chat.
Oh yeah, I was just reading through them. I'm making sure I capture them, so pardon my delay, but I saw Evan Salino's chat. To JC's point, structures for collaboration, coordination, and implementation are key. It's difficult to pull off the collaboration needed to work across orgs, especially as rural providers are so busy. It's hard to find time to coordinate on big project ideas. I think that's a great point. So what Nevada collaborative learning support and implementation structure can help ensure ideas can break down silos. And there is support to develop and implement an impactful and sustainable project. I think that's a really great point. I just wanted to let you know that I'm recording that. Do you have any thing you would like to add to that, Evan? That's all right. You don't have to.
Yeah. Sorry, I just came off mute here. Just the technology is always a piece that's expensive, but seen a lot of technologies bought and then the thought about how to implement or what other people learned in implementing to do it effectively and sustainably is sort of left out of the planning, and that's just such a key step. And ideally, like has been brought up, when you're having similar technologies implemented or used, you ideally can be able to scale the need and therefore the contracts get a better price, those sorts of things. But that takes some collaborative structure. What is that structure, or what is the forum? Where can people find the information and find the partners and have the help to collaborate and think through a project and all the steps, including, again, that sustainability, so hard and so important. How can that happen given just regular life and the timeline of these projects and this sort of thing? So states thinking about that, I think, would be very helpful to come up with a structure for that support.
Well, that's a very great point. Thank you. And I see an interesting comment from Diane that not all rural providers, that word, are nonprofit, which also causes issues with some of those funding solutions. Diane, could you expand on that? Diane McGinnis.
I can. So my company is not a not-for-profit, nor is it a nonprofit. It's a personal corporation. And so items like applying for HRSA grants and things like that, I'm not qualified for those because I am not a nonprofit or not-for-profit. And so some of the funding, if we come up with funding and say it's only for nonprofit and not-for-profit, it leaves providers that are willing to help in the rurals out of that funding, if that makes sense.
Oh, it does. Thank you. And
Diane, that was thank you for sharing that, Diane. That was very, we heard that and are listening to what you just said.
We have a comment from Jerry Reeves. We need information sharing not only of clinical health and medical information, but also health data information sharing to identify care gaps for priority setting and cross-discipline coordination. We need to deploy EMTs and community health workers and dental hygienists and CNAs that can be trained at community schools to use health and social needs information and data to connect rural residents with needed resources. And I've heard that theme throughout this. It's not only the technology, it's the implementation of the technology, the deployment of the technology, and the training of it on and education about the use of it. So I'm starting to see that theme. Jerry, did you want to expand on that, or?
I think that basically we need to optimize the training of high school students and students that are in rural settings. They have chosen and probably will continue to live in rural settings. They know the unmet needs in their community. We can optimize their training to deploy AI and data and tools within their respective training competence to touch base with people that they see at the grocery store and at the church and in their community who they know have needs and can get, when they need the data, and it needs to be measured and tracked as to whether they are achieving better outcomes together. But they are more passionate about meeting the needs of their fellow citizens than someone that's distant and may not be able to identify with the unmet needs as well as someone who's living in the rural setting.
Excellent. Thank you so much. It's very helpful. I'm seeing a couple chats about solutions that seem to be pointing towards success stories. An example of the ambient scribe and HIPAA compliant Doximity. Anyone with an MPI has access for free. A couple call outs on solutions that other folks have discovered. Sorry, the chat's got away. I'm trying to keep up with the chat, so.
Lee, let me jump in. I
Thank you.
think there's a couple questions also here around how do vendors make their solutions known. This is a listening session. I can't offer any solutions on that, but I do think that is that's a pain point that we'll definitely bring back to the state as well. But thank you very much for sharing that. I love this comment also, just to double click on Dr. Bryan's comment. Could we come up with a committee to collaborate and create our own Nevada system for smaller entities using AI? I think that, you know, within the context of RHIT, definitely look at the tracks and look at the outcomes and see if that falls within it. But thank you, Dr. Bryan, for thinking out of the box. I've seen a lot of discussion also on the role of the HIE here. So again, super important to think about and consider. And back to Jerry Reeves and a virtual learning collaborative. I think that that's also really important to think about. How do we think about nurses, doctors, dentists, behavioral health, pharmacy, et cetera? Focus on feasible small projects. Again, I like the idea. The other thing that I've heard here that we've teased out a little bit is that what happens in year one is a foundational for larger transformation that could occur in years 3, 4, and 5. So we need to sort of incrementally think about what does transformation look like in terms of increasing access to care for rural Nevadans. And Mindy has asked a really solid question. Thank you very much for your participation, Mindy. Is the state considering sharing a list of preferred vendors to help providers in Nevada with what's available? Maybe a speed dating event. I love it. Thank you very much. That's absolutely something that has occurred in other states. And there are a lot of state procurement hurdles to doing that, but something that both the state and the federal government have found helpful in terms of increasing awareness to solutions. So thank you very much, Mindy. Thank you for that comment.
This is really helpful. Would you like me to bring down the prompt screen? Because it can be distracting, I know. I just wanted to ask that.
Sure, why don't we do that?
I'm going to stop sharing. I think it can be distracting. Okay.
Okay, team, we're trying to support the state here. For those that have just joined the call, we're trying to support the state as it's developing its procurement for its rural health information technology procurement as part of the Rural Health Transformation Program. This is a listening session. We're trying to understand from individuals on this call what's working in rural to support rural Nevadans with their healthcare and human services. What's working? What are some of the health IT challenges? What are some projects that, now that you've heard everything that people are talking about, that would be interesting to kind of consider? This session does not commit anyone to apply for RHIT funding. We're just listening here to support the state. So your feedback is incredibly important and valuable. Jerry, go for it again.
Talk too much, but we've
Yeah.
really not talked about artificial intelligence applications and training of students and residents in rural settings for how to ask the right questions of AI that can then, they can customize those questions for what has worked in other settings, in other rural settings, in other states, not just what has been tested in Nevada. And how can we build on solutions that have worked in other rural settings internationally? Because there are a lot of similarities between Ghana and Costa Rica and rural Nevada or Alaska. So we don't need to even stick only to US states. There are lessons learned in other domains that we can take some of these lessons learned and best practices and use AI to help us find these solutions such that we can model some of these during this RHIT funding cycle.
Absolutely, and thank you very much. Thank you for sharing that.
And we do not think you talk too much, Jerry. This has been really great.
Well, we'll give this a few more minutes. Again, please feel free to use the chat or raise your hand. Would love to hear from everyone.
Hello.
Hello, jump
Yes,
on in.
We're part of a group of device companies who are relocating in Nevada to do continuous remote information gathering. Anything from high blood pressure to weight for people in wheelchairs to fall detection. And there is not a coalition, there's a group of us are aware, some of which are housed at Rosamond, to actually provide solutions to people either remote or stuck in their homes. And it would be helpful, and I've known Jerry from years ago, we would be willing to participate of a bulletin board to let the companies be aware, because we're trying to integrate the transmission of the data from the remote location to a cloud service. So the data is available for either physician or eventually stochastic prediction recommendation. So I'll be back in touch with the state. We're called Canary MedTech, but there's Vena Vitals and a couple other companies moving here that are doing the same thing in their different areas.
Thank you, Ross. Appreciate
Sure.
that. Again, let me just revisit something that we shared at the very beginning. The purpose around the Rural Health Transformation Program and the RHIT procurement is to support providers. Providers can work with other vendors or other groups to help drive increased access and outcomes for rural Nevadans. So Ross, thank you again for sharing that. Appreciate you. Are there any other questions or thoughts or comments? Would love to hear your perspectives.
I see a comment from Diane. I know many of my rural patients have stopped paying for their landlines and only have mobile phones. So making sure solutions are compatible with mobile phones is important. An example could be interrogating, I think you mean integrating a pacer defibrillator of a patient. Maybe sponsor a high-speed access point in those smaller communities. Thank you.
I actually did mean interrogating. It's a word
Interrogate,
that
I'm
they,
sorry, I couldn't read it. The glasses are down. I
you
took
read
them
it
off
right.
and looked.
Yeah, it's a medical term for if they're like
Okay.
asking it if it's gone off at all or if it's been used. Sorry.
Excellent. Thank you for putting that in context for me. I wasn't sure.
That's a great example. I love it. Thank you so much, Diane.
Yes.
We're looking for good examples also of ways in which health IT can be used and has been used in rural
And when we
communities.
talk about, oh, I'm sorry. I'm thinking about the move to mobile phones. Diane, do you have any thoughts on the use of apps and the resistance to them in some cases? So I think sometimes it can be a little complex for anyone using a mobile phone for certain functions. So have you experienced challenges there?
I'm not seeing as much, but there are some, and that's where Jerry's idea of having like a local guide. So maybe your community health worker or a teenager from the high school could go to some of these homes and help people actually use their mobile devices. But oftentimes what happens is they have, for instance, a mobile phone, but the internet portion of it isn't strong enough to sustain video. So that's what I meant by like a high-speed access point. So it's a library or a spot at the school that was open for community people to come log in and use the Wi-Fi so that they had a higher speed access. They could still use their own phone. They just would be able to actually watch the video or do a virtual teleconference with, say, Dr. Titus or myself or something, if they had that higher speed access to use on their own phone for video.
That is a great comment, and particularly in allowing in community organizations offering these spots, they'd also have to be secure spots with some privacy and security guaranteed. Thank you.
Okay, well, maybe we can take this moment to ask for some last comments, last call for thoughts or questions. And while you guys are thinking about that, if you could pull the slide deck back up and let's go to wrap up and next steps.
Yeah, and there's a question in the chat that you can work through while I'm pulling the slide back up. Thank you.
And Sean, thank you for your question. It has been duly noted.
It just takes me a minute, so pardon this.
So as we go into the wrap up and next steps, I just wanted to reiterate a couple things as the slides are coming back up. Please continue to use the chat function. If you have other ideas that you'd like to share, other promising practices or areas that Health IT has successfully been used with rural Nevadans or in rural communities, please share them. If you have any other thoughts or comments that you'd like the state to hear, please use the chat feature now. You can continue also to raise your hand, and I will stop what I'm saying to call on you. But as we go to the wrap up and next steps, we really appreciate everyone's candid input. So here's how we'll use what we've heard today. We're going to identify some common needs, challenges, and readiness issues across rural, frontier, and tribal providers. We're going to refine our RHIT priorities, project scope, and support approach based on feedback we've heard today. We're going to ensure that we're designing funding requirements that are realistic and aligned with where providers are at. And as this slide emphasizes, this session does not compel you or commit you to apply for RHIT funding. This is an information gathering session to make this program fit the real world. Again, if you have additional feedback, please continue to use the chat feature. We want to capture things and make sure we haven't missed anything. So now let's go into a little bit about some resources. Next slide. Oh, thank you very much. Before we get to, sorry, no, yeah. So a little bit, we've talked a little bit about the CMS technology framework and ecosystem. So this slide provides just a little more detail on that framework and expectations for interoperability and trust. On the provider side, the framework describes capabilities like querying for clinical and claims data for treatment purposes, using identity verification and good standing in the National Provider Directory, and responding to certain patient queries with discretion for sensitive data and all applicable laws. And San's got a question. Lee, I can't read the question. I just saw it pop up.
One quick question. What would look like a consumer-facing tool? For example, lifestyle coaching app for chronic disease like diabetes, hypertension, to take care of diet, exercise, and track metrics. That's a good example of a consumer-facing tool. Yes, that can be used as a consumer-facing tool. There's some guardrails of consumer-facing tools that they cannot be replace anything a provider service, but they can complement that service.
So the consumer-facing tool can engage in clinical decision-making, but it can support a provider in their clinical decision-making. Okay, at the network level, just to keep moving forward on this slide, general network capabilities at the network level, this CMS technology framework is looking at CMS-approved patient matching logic, responding with requested structured and unstructured data where needed, supporting patient, provider, and payer use cases, handling purpose of use, as well as publishing provider directory data usage statistics, which is also really, really interesting. Like how many providers within a provider directory, what's their usage? So the slide also makes reference to certification. HITRUST certified is been called out within the CMS technology framework. HITRUST is a certification on security, and there's an assessment process that is part of the HITRUST certification, and then there's a certification process, and then the third piece after that, which would be beyond the HITRUST certification, is the implementation piece, implementing a sort of a solution, a vendor solution to address a provider's security and risk issues. Next slide, please. And finally, we have some resources here. The resources here talk a little bit about the CMS Health Tech ecosystem, the CMS Rural Health Transformation Program, a link to the Rural Health Transformation Grant, and a link to the Nevada Rural Health Transformation Grant application, which was the grant application the state submitted to CMS to get their Rural Health Transformation Program. So just some publicly available documents around what is Rural Health Transformation Program and what has the state applied for. Next slide, please. With a few minutes left before we close out our listening session, if there's any comments, I'd love to hear them. The two questions I have: what was helpful about today's session, or were there any opportunities for improvement? Would love to hear real-time feedback on what you all just experienced.
Oh, just a couple of mechanical questions.
Go for it, Ross.
Is there a link where we can actually get the slides that were presented today, or?
Yes, the slides will be available on our meetings page for the Rural Health Transformation program. And at the very beginning of the chat, I put the link in there, but I'll go ahead and drop it in again.
Thank you,
They're not
Vern.
available right this minute, but they will be here shortly.
And as a recording of this session, I have a partner that couldn't make the meeting.
Yes, that will also be posted to the same webpage.
Thank you.
Thank you,
We
Ross.
hope
Thank you,
you'll-
Melinda.
We hope you'll all participate in this exciting opportunity. It really is a good opportunity to improve your health IT infrastructure. So we encourage you to think about projects that might expand access to care and improve outcomes for your rural health residents. I wanted to emphasize that the focus is on improving healthcare for improving IT and improving healthcare, improving outcomes for rural residents, but that doesn't necessarily mean that you can't partner with an urban-based provider. For instance, to provide telehealth services to more rural areas of the state. So I don't think we made that clear in the beginning too, but the lead applicant should be a rural provider, a rural or tribal provider.
So as we close out today's session, you can also submit additional questions or thoughts to rhtp@nvha.nv.gov after today's event. Additionally, Melinda's put in the chat here the recording and the PDF of the PowerPoint will be posted to this webpage, RHT Meetings. And with that, I'll give you guys another 1 or 2 minutes if you want to share anything. Otherwise, we'll be closing out the session shortly. I want to have a huge shout out to everyone who did show up today. I think at one point we had about 120 people here. That's great. 120 discrete logins. And thank you, Donna, for that question. We can definitely take that back to the state, or you can email the state that question directly. Donna, you can also include your email when you email the state at rhtp@nvha.nv.gov so that they have a way to get back in touch with you. Okay, I want to say thank you again to everybody for participating today. Thank you so much for this listening session, and thank you so much to the leadership team at NVHA. Melinda, thank you for all that you're doing for the state.
Yes, thank you all. Appreciate it. Have a good day, everyone.